You're listening to 3CR Radio.
Gilda, there's been reports that several people have been cured of HIV, but what's really going on there? Are they just in remission? How does it work scientifically?
Right, so I think it's probably a bit premature for at least talking about the London patient as being a cure. Probably the best that we can say it's remission at this stage. And I think it's potentially exciting because it indicates that the first individual, the Berlin patient, Timothy Brown, indicates it's probably not a fluke that that individual has been living without HIV for about 10 years. So it's basically not a fluke. And what's going on there, if we look at the London patient, we can see there are some parallels with Timothy Brown. So these individuals have had bone marrow transplants, what's called the delta CCR5 mutation. So the CCR5 is a receptor on white blood cells that HIV virus uses to gain entry. So individuals with that mutation tend to be resistant against HIV transmission. So they've received cells from a delta CCR5. The other thing that is common between the two patients is they've had graft versus host disease. It's a mild version of that, and basically what that means is that, having an allogeneic stem cell transplant, there's probably a little bit of a mismatch between the donor cells that were put into those patients and the recipient cells. And so the immune response is probably kicking in and killing in any cells that have been left in the donor. So both of those in concert probably tell us or give us clues as to strategies for developing a cure strategy, if you know what I mean. So what it actually tells us is, firstly, if we can target the CCR5 receptor, that might be a way of curing, but you'd have to make sure that you can get rid of that receptor in every cell that's susceptible to HIV. So you're probably thinking about gene therapy, CRISPR, something along those lines. And then the other clue that it gives us is that you probably might need an immune response, so the immune response to target any HIV-infected cells that might be left in the body. So maybe, you need both. So that's probably what's going on. I think it's really exciting news. In terms of this being a way that or a strategy or a cure strategy that you can roll out for everybody, that is not a viable option, and that's because this type of treatment is dangerous, if you like, and you'd only be using it in individuals who need a bone marrow transplant because they've got cancer and they've got no other options. So in terms of a tractable way of curing individuals, this is not the strategy, but it does give us clues as to how we can proceed with cure strategies in the future.
What's dangerous about it?
Oh, with what has these individuals? Yeah, look, stem cell bone marrow transplant is not something that you can do to individuals who are on antiretroviral therapy, where their virus is controlled and, they're doing really well. It's dangerous because there's mortality associated with transplants because of graft versus host disease and all the treatments that they have and the conditioning that they have. There can be mortality about 10 to 20%. So it's pretty much a last resort for these individuals. The other thing is that actually getting a donor match is difficult. Only 1% of Caucasians will have that delta CCR5 mutation. So finding a donor with that mutation that is actually an allogeneic match will be challenging as well. So, it's exciting. It tells us the way forward, but it's not something that we're going to be rolling out to people living with HIV to cure them.
An injectable monthly HIV treatment is being developed. How far away is that from being a reality for people living with HIV?
It's probably fairly close. At CROI there were a few presentations, and these were open label studies, so phase 3. And, the studies are look quite promising. So the ones that are available, the drugs that are available, are long-acting cabotegravir and rilpivirine. And in that context, they've been looking at individuals who've been on suppressive antiretroviral therapy, so their virus load is undetectable for a while, at least 6 months, and then they'll come in with these long-acting injectables. I don't know if you know how it works, but it's about a couple of mils of these drugs into the buttock. But before they can do that, they need to make sure that there's no adverse reactions due to the drug, and that means that those individuals initially will go on oral therapy that contains those drugs to make sure there's no drug reactions. And then once that's fine, so they call it a drug lead-in, once that's all okay, then they'll get the injectables, and they'll have the drug in their system for about a month. But what happens then is that if they don't come back for their second injection after a month, you have what's called a tail. So the levels of the drugs are going to be decreasing in the body, and that is problematic if the individual is HIV positive, because you'll have suboptimal drug levels which can select for drug resistance. So you need an individual who is compliant, who is going to take, make sure that they go back and have their injection every month. There can also be adverse side effects with other drugs, and it's important to remember, once that you get that injection, there's no going back. So it's in your system and you can't get it out for a month or more. So you need to take that into consideration. But having said that, it looks like individuals who have participated in these trials have found it quite acceptable, about 80%. They prefer to take it than oral. I always like to say, you don't have one size fits all. Some people might prefer to take tablets orally daily, but there might be individuals who might prefer the injectables. It could be more convenient for individuals who may be travelling and they don't have to carry their pills around. And I think an interesting concept is that there are, young women in sub-Saharan Africa who might have their pills in their purse, and that sound of the pills in the purse, is recognised by their partners, and there could be stigma associated with that, and think, well, what are you taking these pills for? So an injectable would be a discreet way of protecting an individual who is HIV positive. So in terms of how far off we are, fairly close. The question would be, how much would it cost? And presumably, for resource poor settings, it might be a little bit longer before it becomes available. But, it's an exciting thing, and it's great to have a variety of ways to be able to get treatment. It's also been looked at in terms of prevention as well. So individuals who are high risk of HIV infection or are HIV negative, there are trials looking at getting an injectable to protect themselves against HIV instead of taking a pill daily. So
injectable PrEP?
Yeah, absolutely. Yeah.
Gilda,
exciting.
Tell us about some of your current work regarding women and HIV. I know you're kind of at the forefront of that field.
Yeah, we're delighted to talk about that. So I guess in Australia, when we think about HIV, we probably don't think about women, but globally, individuals who are infected with HIV, women would be almost 50% globally of the 1.8 million that have been infected in 2017. And the majority of those individuals are actually in sub-Saharan Africa. And there's some incredible statistics, like 7,000 women and girls get infected a day globally. So it's quite a big problem. And again, the statistics show that in sub-Saharan Africa, adolescent girls and young women are up to 3 times more likely to be infected with HIV compared to their male counterparts. And we know there are gender-based issues that are causing that or promoting that. So when you've got young girls that are having sex with older male partners are more likely to be infected with HIV. But they're also now, we're beginning to understand that there are biological factors that are also driving this increased risk. genetic. And remarkably, it has to do with the microbiome. And in fact, the vaginal microbiome. So the microbiome is a collection of bacteria and viruses and fungi that colonise all surfaces of our body. And with these young girls in sub-Saharan Africa, they do have a vaginal microbiome, but it's not optimal. And this non-optimal microbiota is associated with what we call genital inflammation, so subclinical genital inflammation. And that genital inflammation results in recruitment of HIV target cells to the lower female reproductive tract, and also diminishes the epithelial barrier or the mucosal barrier, so that the virus has a greater chance of getting through that barrier to infect target cells. And so what we've been asking over the past 7 years is, okay, all right, so relative to these women with the non-optimal microbiota, you have women who seem to be protected against HIV, and they have beneficial bacteria, and these bacteria tend to be what we call lactobacillus species. And these lactobacilli produce products, and one of the major products is lactic acid. And lactic acid does remarkable things in the vagina. It acidifies the vagina to a low pH of around 3.8. And this is an interesting fact that women are the only mammals that have acidic vaginas. And that acidity is important because it kills pathogens and viruses. But we've also found that those lactobacilli and others, that the lactobacilli are associated with a non-inflammatory environment that would help protect against HIV. So we've been looking in the laboratory at the properties of lactic acid. We've shown that it is really potent at killing HIV in the test tube, better than just acid alone. We've also shown that if we take epithelial cells from the lower female reproductive tract, that lactic acid can dampen inflammation in that context. And then our collaborators have shown that this acid can kill the bad bacteria in the vagina, but not the lactobacilli. And so it's a product that's produced by the microbiota that has multiple effects. So what are we doing with these findings? Well, we are actually in the process of formulating a gel that contains this acid, so we can actually ask the question, can it work in women? All these studies we've done so far are in the lab, in the test tube, if you like. And so the next step would be to take women who have these non-optimal microbiota and treat them with this acid with a gel, to see if we can decrease genital inflammation, if we can change the microbiome from a non-optimal to a beneficial microbiota, and see whether, it does what we think we hope it does in vivo. So what we've seen in vitro, we can see that it happens in vivo. And then that will set the platform for us to develop sustained release versions. I mean, we know with gels and with the microbicide field that women don't like to, dose daily with a gel, but we do know from the microbicide field that sustained release in the form of an intravaginal ring would be the way to go. So, something like a Nuva ring, which a woman can insert, won't be able to feel it, but that ring will release the lactic acid, and that would, for about a month, that's what we're thinking, and then that would provide a way to normalise the vaginal microbiota, decrease inflammation associated with HIV risk. And of course, with these rings, you can add other drugs in there. You could add an anti-HIV agent and maybe a contraceptive to have what we call a multi-purpose prevention technology to a ring to that will act at different mechanisms.
3CR